All right, yesterday when we left off, we were talking about elements of blood. And today we're going to pick up, we finished our red blood cells. We learned that a red blood cell is also a erythrocyte and that it's also, we abbreviated RBC. Now today we're going to pick up and we're going to start with leukocytes, white, right? White blood cells, also WBCs. And we know that as a red blood cell delivers oxygen and keeps our body oxygenated in our tissues and our organs, we know that the white blood cell is there for our immunity and to keep us healthy and to prevent infection. Now, a white blood cell count usually includes like the total types of white blood cell. So you know how I was explaining to you that there are different. We expect when we see that total count to be somewhere in the range of 4.5 to 11. All right? And if for whatever reason, you get the printout and it comes through and it says Mrs. Jones WBC is 30. That's going to be what? What does that tell us? Mrs. Jones is inviting a severe infection. Something's going on. It may be an infection, it could be a type of cancer, leukemia, something like that. But something's wrong. It shouldn't be that high. All right. Just like if somebody comes in and their white blood cell count's like a 3, that usually indicates that they've got something viral going on, but it also could be other things as well. So we need to know this range. So you are going to write that down, highlight it, and burn it to memory, because when their labs come back, and if it is highly abnormal, we're going to let the doc know. All right. It's not something that we're just going to place on the desk and let him see it or let her see it later, right? Now, this is just like what I had said. If it's elevated, it usually means a sign of infection. If it's grossly elevated, it could be a severe septic type of infection or a leukemia. With my dad, he had acute myeloid leukemia, and his white blood cells stayed around 30, 35, 40. And during his chemo and all his treatments and stuff like that, until he started going into remission. So that's, like I said, that's why we see numbers like that. We'd automatically alert and let the doc know. Low levels, like I was telling you, usually mean a viral infection. It also could mean autoimmune deficiency. At times, my WBC, my white blood cell count, is slightly low, but it's become that my docs know that 3.5 for me is kind of my normal. And even though the normal is 4.5, and that's because of having an autoimmune disease. When we start, and we did micro, and when we start thinking about extreme bacterial infections, they also can destroy enough of the white blood cells to significantly reduce their numbers and make them drop. Now, there is other blood tests that we can perform besides a complete. There's one called a differential white blood cell count. Basically, what this is doing is it's determining the percentage of each type of the white blood cell. And it's usually something that's done automated, okay? And I'll explain. So, we have our neutrophils, eosinophils, basophils, lymphocytes, and monocytes. A differential is going to give us the number of each of them. And usually we have a range. And the wonderful thing with technology is that we've been able nowadays, whenever you get a lab report back from LabCorp, Quest, something like that, it has the patient's information and what their numbers were with the test name. And then it has a level where it says high, low, or, and then it gives the actual number range. So usually if it's really low, you'll see a gigantic red L. Or if it's really high, it'll be a gigantic red L. Or something like that. Or a star saying abnormal. Most of your labs are really good about pointing out something that's abnormal. Okay. When we get those back, those are also things that if they would grossly abnormal, we'd inform the doctor and let them know as well. A differential white blood count, and this is showing it can be done on a microscopic slide, and we talked a little bit about that in micro. And then this is specifically showing you the white blood cells. So we have our monocyte, our eosinophil, our neutrophil, basophil, lymphocytes, and then they threw the platelets in there. And then you remember what platelets do, right? Platelets are vital for clotting. And that's why they're kind of jaggedy and got lots of little different arms and limbs, because when we have a wound or an injury, those platelets gather and they help seal. They clot, and that's their job. Their job is to keep us from bleeding to death, and that's what platelets do. Now, monocytes are our largest, and we'll go through each one of these and talk about them, but those would be all in a differential. A complete is looking at everything all together, okay? Preparing slides, I'm going to go through that because I have a video. And the video explains all of this. And this is called a blood smear. And just like the picture shows, they're taking a drop of blood and smearing it. And that way the doc can come in there and look underneath and see the patient's blood and take a look if there's an abnormal amount of white blood cells or eosinophils, basophils, stuff like that. And don't worry, the video I show you is an excellent video, and it'll explain all of this. They're staining it to prepare it so everything sticks out. All right, and so like I said, I'll post that video. Now let's get back to talking about the individual white blood cells. Our first is our neutrophil, okay? Our neutrophil, this is the white blood cell we have the most of, okay? So that you'd want to write down and take a note. Neutrophils are the one we have the most abundance of, all right? And they're our primary defense. Neutrophils are usually ones that we consider phagocytic, and this means that the Pac-Man, wonk, 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 remember in micro? And they go around and they engulf and surround, swallow, and Pac-Man anything that they find foreign, all right? That's phagocytosis, that process, in case you don't remember from micro. And they're usually segmented, a mature cell with a nucleus that's divided into multiple segments, okay? So that's what the doctor would be looking for. Main thing I want you to know about them is they're the most common, and that they are phagocytic. So they are our Pac-Mans of the blood. And this is showing like, but we've got way better pictures of phagocytosis than this. And this is actually what you would see, a neutrophil that is segmented versus a neutrophil that are bent. We don't have to go into all that because this is above, like, you know how I like to say, your pay grade. Insophils. Okay, so our insophils are our next. Let me go back real quick. So, neutrophils, the most abundant white blood cell, and their Pac-Man phagocytosis, right? Okay, that's what you need to know. Now, insophils, all right? So, they're, when we see a large number of insophils, as an MA, that should make us go, because usually we see insophils for just a few reasons. A large number indicates the patient could have parasites, or they've had or having some type of allergic reaction and or allergic condition, okay? And so they're usually in very small amounts of the blood, the overall white blood cell count. So when we see them in larger amounts, they kind of stick out and go, what are those doing here for? See what I mean? They're not normal. Basophils, they play an important job. And if you remember this medicine right here, heparin, and what was heparin? Heparin thins the blood, all right? So when we think about that, they play a very important part of keeping our blood moving and flowing and keeping that congestion from forming and blocking up our highway. Patients who have had their spleen removed, a splenectomy, they may have an increased amount of basophils. People who are going through radiation therapy may also have an increased amount of basophils. Oh, that's the other thing, the last thing about basophils. Wherever there is a allergic reaction, because they contain histamines, you're usually going to see a large grouping or quantity of them in that specific targeted area for basophils. But mainly just know for them that they're what keep the traffic moving because of their blood thinning property. And when we see them in really large concentrations, that usually means somebody's had an allergic reaction. Okay? Lymphocytes. Now we just talked all about the lymphatic system, and we know about that. We know that the lymphatic system is the secondary circulatory system. And what is its job? Its job is to transport lymph fluid and white blood cells and all of the good stuff to keep us safe and healthy. And it integrates throughout the entire body to our tissues and our organs. And lymphocytes themselves are, even though they're produced in the bone marrow, they're also found in lymph tissue and lymph nodes. And this is what I want you to write down, their primary function is when we think about antibodies, okay? Whenever something comes in foreign, an antigen, they are what helps us with the antibodies and producing those antibodies. So they're small and large. They can be either B, remember us talking about B cells and T cells way back? And B, we know, stands for bone-derived. T thymus derived, right? But our lymphocytes, how I want you to think about them is that they have a close relationship with lymph nodes, okay? And the main thing right here, antibodies, okay? That's what you should associate with them. And they are the second largest percentage of white blood cells that we have. We use lymphocyte testing as far as when we test people with HIV, because it allows us to see how many T cells. And if y'all remember back when we learned about HIV, I said the key to keeping a patient alive is antivirals, because the virus itself destroys and destructs all of the T cells. And if we go back and we dust off that part of our memory, we remember that our thymus is only active from infancy, like to basically like puberty. And it is what makes all of our T cells. After it's done its job, it kind of shrivels up and becomes dormant. So all the T cells you're ever going to have are already made. You get HIV, it destroys the T cells. So how do we keep our HIV patients safe and healthy? We put them on antivirals to keep them T cell safe. And that's one of the ways they look at it, is doing a test specifically for lymphocytes and checking the T cells. Now monocytes are our largest white blood cell, all right? And they also assist with the Pac-Man phagocytosis, all right? They're big, so anything that a neutrophil isn't able to take care of, the monocytes come back around and like, hey, I got that. They're a cleanup crew, all right? Anything that's left around, they're there to take care of. So 2 things with monocytes. They're the largest, and they're there to help clean up and keep our immune system and everything flowing freely of debris and anything that's been left behind. When we see, there's 2 things. When we see a patient who comes in who has an increased level of monocytes, that's not usually good, okay? Because this is associated with tuberculosis, typhoid, which we don't see too much, and Rocky Mountain spotted fever. And that's similar to like the tick Lyme disease. So we don't want to see an increased amount of them, because that means the body's doing extra cleanup methods and stuff like that. So our monocytes, we want them to stay within their range, and that's usually 3 to 7% of the white blood cell count. And then platelets. When we think about platelets, or we also call a platelet what? A thrombocyte. Now, here's some facts you would write down about them. They are the smallest, and they don't live very long. They're about 10 days, and they are consistently being reproduced. And if it was not for platelets, we would not be able to stop bleeding. If we, cut ourselves while cooking dinner, we would just bleed and bleed and bleed, unless you, put a tourniquet. But because our platelets are there for coagulation, clotting, okay? And they also assist in the healing. And this is something I want you to write down and know. Your normal platelet count is 150K to 400K. okay? And those numbers are very important. And I'm going to tell you, you're going to need these, especially if you work general practitioner or with geriatric patients. These numbers, because so many of your patients are going to be on anticoagulant drug therapies like Coumadin and such. Um, uh, when they have their blood work done, and they do it often, and it's to make sure that the medicine that they're on is working right, because too much of the blood thinner, they could bleed out if cut. Too little of the blood thinner, and they might form blood clots and have a stroke. So it's very, very important that when these numbers come in, we take notice of them. And if they are abnormal, we inform the doctor. There are terms that we use. A platelet count of over 750K would be thrombocytosis. A platelet count of less than 50,000 would be thrombocytopenia. All right. And this is too little, right? So we don't want either one of them. We want that homeostasis, that balance. If we see a patient, this is a mark this down, write this, and their numbers are ever less than this, that's something you immediately let the doctor know, because this could be they're bleeding internally. Something is seriously wrong if you see somebody with 30 or 25, something like that, that those would be 25K would be something like, whoa. And we've seen that, with internal bleeding and that kind of stuff. And this is the test that I was talking about. This is our first blood test that we're, besides the CBC and the RBC. This is the next one we're going to learn. And it is called a few different names. But basically, what they're all doing is looking at the thrombocytes. They're looking at how fast the blood responds, clots, and activates that process. So that's called prothrombin time, and that's PT. It's also called ProTime. You also have what's called internationally normalized ratio, or INR. So what you'll usually see is the doctor order a PT INR. So you'll say PT INR, okay? And the PT is the test that it measures the amount of time it takes to form a clot. So how long does it take that person's blood to coagulate? That's what PT is, okay? Now, INR is slightly different. With if a patient has certain underlying conditions, systemic conditions, especially liver failure, these tests might be messed up. They might not be 100% accurate. All right. With a patient who has a typical bleeding time, their average adult clotting is 10 to 14 seconds. Higher than 30 seconds, or 4.5 for the INR, that's a risk for bleeding. And then more than 40 seconds, that's critical, crucial. All of those numbers, I'm not too worried that you know. If we go back here and we look at this, these are what I want you to know, okay? I want you to know platelets are used to clot, all right? Coagulation. And that if you have too many That's thrombocytosis. If you have too few, that's thrombocytopenia. Too few is very dangerous because it means you probably have internal bleeding. Too many, you're very likely to form blood clots and strokes. That's what y'all need to know. And it's 30 minutes, so I'm going to end that here. And I appreciate you joining me. And y'all have a good day. And tomorrow, hopefully, I'll be able to jump in and get lecture a little earlier. Okay? Anybody have questions? No? All righty.
No.
All right. Have a good day. Bye, guys. Make sure you hang up.
You too. Bye bye.